Good morning, everybody. Thank you for coming to this session. Thank you, Nicola, for that really kind introduction. So I am dual registered, so I started my career as a biomedical scientist, got all the way up to Chief BMS before flipping over to clinical science and starting HSST. This is my thoughts, my words, my experience, things that I have heard from others, my thoughts echoed in their feelings as they've gone through this training program. And it's difficult at this stage to really understand the enormity of what I've done, being one of the first to go through it for microbiology, but also being one of the first that has walked both career paths and has a good understanding of the requirements of both jobs. So although you shouldn't be taking pictures as I'm going along, I'm happy to share these slides afterwards. Drop me an email, and if this is something that you are seriously considering, I'm always happy to have a conversation about the course. What I'd really like to do, and it's hard because the lights are shining, would you give me a wave if you've got a HSST in your service? Okay. Give me a wave if you are the HSST. Okay, that's really interesting. So you're all people that are mentoring and supporting HSSTs. Okay, excellent. And give me another little wave if you're in microbiology. Okay, and another if you're in biochemistry. Fab. And I'll explain why I'm asking about those two in particular as we carry on. That's really helpful for me to know. So this is old news now, but a lot of work happened behind the scenes to make sure that senior biomedical scientists could access the higher specialty training program without having to do equivalence first. And this came through in April 2021, so we're now seeing people that are registered as biomedical scientists enter the HSST program. Obviously, there is still an option for people on the program to consider equivalence at any point that they are on the program, but it's not a barrier to you entering the program. Amazingly, I do still get asked about this, and I get asked, I've got this really promising band 5, can they start HSST? And I have to continuously refer people back and manage people's expectations that yes, they can start HSST probably in about 5 years when they've got through all of their BMS specialist portfolios, their masters or equivalent. So it's good to keep bringing people back to this so that they understand the career timelines that come into play when you're trying to grow your own HSST. So this is the workforce data, and thank you to Lisa for providing this for me. And that's the reason why I asked about biochemistry and microbiology, because by a long way in life sciences, the most populous training groups are the biochemists, who I consider to be very au fait with putting people through FRCPath exams, managing the transition to consultancy and having in-house training programs. I consider that they're the ones that really know what they're doing. And the ones that are the new kids on the block but have hundreds of people, it feels, going through the program are the microbiology teams. So we have 44 HSSTs across microbiology, and that obviously presents some challenges for the University of Manchester in providing supervisors for all of those PhD projects. So what I want to talk to you about today, as you're all quite aware of HSST, as you've all got people going through it, is the alternative pathways of getting through HSST and how we could be more prepared for putting people through this program by front-loading some of HSST or looking at our individuals and working out a very specific training program that would actually be more suited to their needs. And it's not something that we have traditionally done in life sciences. We've never really looked at people and thought this could be a 10, 15-year career plan for this individual. And I want you to take some of the wisdom that occurred around my training, that it really was a 10, 15-year plan, and it started at an appraisal in 2013, and I entered the course in 2015, and I'm just coming to the end of it now. So it's been a really long journey for me. Have a look at the numbers that have completed, and that's not to frighten anybody by any means at the difference. It really shows the popularity of HSST, that this really has become the thing that people want to do if they've got an inkling of desire to be any sort of clinical practitioner. This is the course that people are pushing at their appraisal to get to. But it is a difficult course, and obviously the pandemic has caused a little bit of disruption to people finishing HSST in the 5 to 6 year framework. So this is the programme, this is the overview. I hope it projects okay, because they're directly taken from the introductory slides of the HSST programme. The hyperlink is there. So the vast majority of people that are doing the HSST fall into pathway 2. So these are people that come in without part 1, without a PhD. They're trying to do in 6 years the entirety of this programme. And as you can see, it's a lot. The minimum starting point, as we all know, is Band 7 pay. I would say it's Band 7 experience is the starting point. You want somebody that really truly understands the pillars of quality, the governance of your laboratory, and that has had some form of clinical education, whether that's attending specialist MDTs, whether that's authorization of reports, or whether it's leading research and development with your clinical team. But that person needs to be primed and prepared before turning up on the first day of this course. So the pathway that we don't use is pathway 1. And this is the pathway that, forgive me for being generalist, but the pathway that a lot of biochemists use, where they see HSST as a long-term career pathway, and people often do their FRCPath outside of the programme, FRCPath Part 1 outside of the programme, or they start their PhD outside of the programme. The very early microbiologists that came into HSST already had Part 1 and already had their doctorates, and spent 4 or 5 years really honing their clinical skills to get ready for Part 2. So I just want to put that thought out there, that there is another pathway, and there is an alternative to a 5 to 6 year zoom through pathway. I make no apologies for this being controversial, because I think it is wildly misunderstood. And I do hear frequently that staff are still doing their old job while starting this training pathway, and their 20-80% split is 20% is for your entire HSST and 80% is for your day job as a BMS. And you just fit your HSST into that 1 day a week. And that really isn't how the programme is intended to be run. From day 1, you are training to be a consultant. You are developing those behaviours, those attitudes. You are becoming globally aware of the hospital system, the governance procedures. There may be in your 4 or 5 years of training only 1 or 2 outbreaks with a very difficult to treat organism, or 1 or 2 scenarios that arise, and you need to be seeing that within your clinical training. So what I would say is 80% of your time is on-the-job learning. You should be shadowing your consultant team, whether that's medical or clinical scientific consultant. You should be working as part of a team, whether that's with the registrars, if you happen to have them, or it's with the wider clinical team. Obviously, you have to attend university, and you have to start thinking early about your research. And you also have to think about CPD and professional courses. So if you look at what a registrar would be expected to do whilst they are in training and mirror the same kind of courses, that's exactly what your HSST should be doing. From my CV, that will be medical statistics, that will be infection prevention control courses, developing certificates and foundations and expert practice in some of those specialist areas. So the 20% really is your time to trust your trainee. That's their time to do self-directed study. And it isn't enough time. We talk about this being a 5-day course, but at your induction in Manchester, you're quite honestly told it will be, a course that you are completing in the evenings and weekends, and there has to be some acceptance that some of that self-directed study time will impact on the way that you deliver your life pre-HSST. So I made this infographic to show over the 5 years how you progress through. And obviously for your Section A units, which is your postgrad diploma in healthcare leadership and management, you've got the option to follow a fast track, completing that in 2 years, and you've got the option to follow a standard track. So that's 5 modules of leadership and healthcare management that account for 20% of the taught doctorate. And those modules are level 8, they are intense. There's 2 pieces of coursework for every module, and for every piece of coursework you've got about 80 to 100 hours of reading to complete those assignments. So that 20% self-study time is really needed, especially if you are doing the fast track. The other components of your doctorate is Section B, which you should be doing within your first 2 years. So that's your Part 1. And your Section C, which starts once your Part 1 is completed, is your research and innovation and development projects. Now, your Pathway 2 here is doing that full project. If you have already done your PhD prior to starting, then you would do a slightly different research project. The other thing you have to fit into all of this is Part 2. And Part 2 is your higher speciality training. So if you were a medical trainee going through their 5-year program, then they count all the time clinically learning after Part 1 as higher speciality time. So it's no mystery that our titles are the same as our medical colleagues. They enter higher speciality training, HST, after their Part 1 is completed. And we enter our HSST stream as well once our Part 1 is completed. So you will look at all of this and think, how is there enough time to get through all of these components? And that's where you come in as their mentors, as their supporters. You're the one that has to try and wrestle with their ambition, and you have to keep them on track in delivering these milestones alongside completing their one file, which is their record of competency, clinical and technical and quality competencies. So that's the overview as I see it. Very much from the finish line, this is how it's broken down for me. The other bit at the top in yellow is the years that are funded, and the bit in pink is anything that's done after year 5 is unfunded. So you have to manage that money and manage their expectations and make sure that when they're going into their Viva and their corrections window that there's still some money left if they need to do a little bit more wet work to complete their doctorate project. So I'm going to talk a little bit about each of these elements of the pathway. So your one file really is the equivalent of your portfolio. It's the equivalent of your medical training portfolio. It covers all of the knowledge that you are expected to acquire and the competencies that you're expected to achieve. There is an expectation that you will start off showing some degree of competency, and by the time you're hitting year 4 and year 5, you should be competent to do those tasks independently. And that should be assessed by your clinical supervisor, whether that's your medical or scientific consultant supervisor. So the knowledge builds, and very much once you're hitting your year 5, you should be hitting the higher level competencies. So you should be attending conferences, speaking at conferences, having some form of national impact in your speciality area. You need to be integrated with existing research developments, looking at what's happening with the NIHR, with other biomedical research groups. You need to have a solid understanding of how research is delivered in your trust across your partner organisations. And really you should be integrated and attending some of those meetings so that you're aware of the landscape that you're working in. Specialist societies, having a role in multiple or single speciality societies, but you need to show that you are capable of partnership working. These are consultant behaviours and consultant practices, and we have to remember that although we call people HSSTs, they are a consultant in waiting, and it's very important to get those behaviours established early. The other thing that I mention here is CV building. So at the end of this programme, you are very much judged on the quality of your portfolio, which isn't to say that that goes into your job interviews, but what does go into your job interviews is your CV and your job applications. And there is an expectation that you will have attended conferences, presented posters, and won prizes. So I'll put that out there and not say too much more about it. But the benchmarking really of this programme is looking at the guidance that the Royal College has put out on how to appoint a consultant clinical scientist. We should be in our early stages looking at the end point assessment. Begin with the end in mind. That's one of my mantras. So you should look at what the expectation is in that job description. They are highly banded, a minimum of 8D. This is a very big job you're preparing somebody to do. You need to have a look at job plans. You need to have a look at how much audit and speciality time you're going to give that person, whether they're going to have a CPD budget, and whether they're going to have access to study leave once they're in their consultant role. So for me, developing a consultant, you are trying to get a biomedical or clinical scientist to the very peak of our career. There is no other role that is this steep in the NHS where you can start as a band 7 and end as an 8D in 5 years. There is no other mountain that is quite that high to climb and that quick to climb. And I think if you're supporting somebody through this, then that's the thing that we have to remember, is that we're pushing somebody up a hill in a very, very rapid way. And this, for me, is serious business. Our reputation as training officers, as laboratory managers and scientists is on the line here. We can't be getting people to this hill and them be failing when they're at the top of it. We need to make sure that our reputation as scientists is held together here. We're going to grow our own consultants. What an exciting proposition. There are people who may not be in this room who would have loved this career path had it been around when they started their journey in biomedical science. And I think that's something that we have to keep remembering, is that it is very much a privilege that the Royal College has opened its doors and allows our members to sit their exams. I'll briefly mention it and not dwell upon it, but we work under Agenda for Change terms and conditions. That is a knowledge and skills framework that rewards acquisition of knowledge and enhancement of skills. And it would be remiss of me to not say that starting as a band 7 and rapidly going towards an 8D shouldn't come with some form of pay review. There is an annex in Agenda for Change, Annex 21, that allows you to be paid in incremental grades of the final job. But you have to be at the point that you could be appointed to that final job to really start entering that Annex 21 process. So it usually is only relevant once somebody has passed their Part 1, passed their PGD, and is at the border of being appointable for a consultant position. But I would implore you to have a look at it if you've not looked at it already, and have an oversight of the ways that you can enhance pay for people going through this programme. So Section A, I'll not dwell too much because I've mentioned it already, but this is delivered by the University of Manchester team. It's high-level stuff. It's a lot of policy. It's understanding how the King's Fund works. It's understanding the levers behind all of these 10-year plans, how they are put together. As a consultant scientist, you will be leading and developing a service, and you should be very much aware of the global landscape of what we work in. Part 1, typically for people that are coming in straight into the programme, it's 12 to 18 months of preparation. There's some misunderstanding that Royal College exams are easy for scientists, that they are scientific exams. They're absolutely not. They're clinical exams, and they are designed to check that you understand the reasoning behind the testing processes and that you're clinically safe to utilise those tests. Most of the exams, the pass rate's about 50%, so toss a coin. And that's one of the things that if you are mentoring people through this programme, you're not taught how to build resilience in these individuals, and there'll be times when these individuals are tired and when their batteries are very low, and they will need to be reminded that this is a strenuous and difficult program, and that half the people who are good, excellent people, but half the people will be sitting those exams again. The doctorate is level 8, so novel research. You're expected to challenge yourself. We were told aim for nature. That's where we should be thinking. Obviously, not very many people publish in Nature, but it's not to say that we shouldn't be ambitious. We should have those thoughts in mind, that this is your chance as a service leader to have money in your department to do all the research you've wanted to do. And it's not a huge amount of money, but it can still push boundaries. So it's something that your trainee has to be interested in, but obviously it has to be something that can be academically supported in your team as well. So the innovation project is where you probably really help, because people need to understand how to translate research into business cases and how to get new equipment and new techniques integrated into the NHS. Mentoring is absolutely needed for this section, and this is probably where they will lean on their seasoned and experienced chief and laboratory managers and service managers. So part 2, it's the same as part 1, depending upon the speciality you're in. I think virology has got the lowest pass rates at first attempts. I think biochemistry is pretty solid and high. Microbiology is around 50%. So again, it's well prepared people that have great knowledge and understanding, but 50% will not pass that exam. And there needs to be some resilience built in for how that person will feel when they have worked really hard for a year and they've not made the grade. This examination, although we're encouraging our HSSTs to work as part of a team, this confers fellowship membership to the Royal College, and that infers that you are capable of individual decision making and working as a consultant, and that can feel quite daunting and quite lonely to realise that this really is your rubber stamp to say yes, your knowledge is sufficient for you to be a single sole decision maker. So again, it's a huge exam, and it is also enhanced by the kind of work you're doing in your portfolio. So this is my plea to everybody here, really, is look at your people, look at the core person specification. What we don't want to do is set our good people up to fail. We need to get our ducks in a row. If we're thinking about HSSTs, we need to think early. We need to get level 8 ready. Is there an alternative to Pathway 2? Could we be putting people through Pathway 1? Is there funding in our trust to do PhDs? We now have NIHR fellowships open to scientists. They're open to biomedical scientists. There's pots of money in the IBMS that can grow consultant BMSs. There's ways to preload our trainees through a structured career development program that we can manage before we push them into HSST. What I like to see from people that are starting off HSST is that they understand how to mentor others, that they understand what M level is, they understand what level 8 is, they are used to R&D activity, and they understand the frustrations that come with that, you know, getting everything in to run a project might take you a year. Finding the people in your trust that release money or sign off ethics, you know, that might be another year. You need to get FRCPath ready. So we as scientists can't run this program without medical support. It's absolutely impossible. We need our regional training officers. We need to ask their permission to send our HSTs along to regional training and teaching events. We need to be signing everybody up for the most they can possibly fit in their first 3 years. There's a lot of independent study expected, and what I would say is you are going to have to encourage the individual to find their stride with that, to find their comfortable ways of working and find where they can maximise their time where they have the least distraction. So we need to get our ducks in a row. We need to develop a post. We need to plan how that post will be funded, whether it's going to be medically funded or whether it's going to be laboratory budget funded. We need to think early about how we move somebody into this role. It's not a job you do on the side. It is the job. And we have to be respectful and mindful that there are medical trainees running through this programme or equivalent to this programme, and they are getting a lot of time and a lot of support regionally and nationally through the colleges, and we need to make sure our trainees get the same. I think it's possible, you know, to have a village for one trainee. You might have in your department nobody with a doctorate. You might have nobody that's done an MBA or has done a healthcare leadership master's, but there probably is across pathology. And if there's not in your pathology department, there will be across the region. So it's about building those networks ahead of somebody starting and pulling those people in and asking them, would you spend a little bit of time mentoring my trainee? I've had support from immunologists, from biochemists, anybody that was across pathology that had a higher degree, I went to meet them. So are we ready for it? Do we have the tools? Do we have the will? Are we going to be putting people at the top of that hill? We can't lose sight of the summit here. They are your trainee. This might be somebody you've known since they were band 5, band 6, they're now a band 7. But you are encouraging them to walk alone. You are encouraging them to get to the top of that mountain and make a huge difference to the landscape of this career. They might not do it straight away, but across their working life, they will do it. I'm not saying leave them unsupported, because at the end they're going to be on their own, but there has to be some acceptance that we're encouraging these people to fly and to really achieve the peak of our career. Workforce shortages absolutely are pushing us all to work differently, the locum bills that come in for our consultants, but this isn't a quick fix. You know, if we want to put our BMSs through this programme, it's not quick. It takes the same amount of time to put a medic through it as it does to put a scientist through it. And if you've got to the point where you're managing a fragile service, where you're hemorrhaging your consultant team, you probably haven't got the support for a trainee. And that's not to say that you couldn't still do it, but you probably need to look at network level and regional level support for somebody if your service is clinically fragile. So this is, in my view, an opportunity of a lifetime, but we have to pick the right person, and we have to accept that we are needing to offer support that maybe we're not that comfortable offering. Maybe we don't feel that we can mentor somebody through the clinical components of this. But we have to guide them, and we have to be the person that finds the people that can, because your network and your contacts will be invaluable to your trainee. So that's it for me. That's the hill. I'm almost at the very top of it, and certainly I've not walked up it alone. So I've got a smidgy bit of time for questions. I should have talked quicker.